Good morning, my name is Jorge Alio. I am in Alicante, Spain, and I'm going to show to you my comments about the video of the month, which is from Tushya Om Parkash from India, dealing about how to spare the central part of the epithelium when performing cross-linking, debridement only the peripheral part of the cornea. This video targets an important problem with collagen cross-linking, which is the delay visual recovery and the symptoms of the patient following the surgery that are very unacceptable for many of them and disabling, making them not to be able to perform a normal life for a consistent number of days. With this respect of the central corneal epithelium, the authors target not to affect the penetration of the riboflavin and not to interfere with the positive action of collagen cross-linking at the cornea, but rather to improve the epithelial recovery. As the central part of the cornea will have the epithelium, the vision will be not that affected initially, and definitely the recovery of the epithelium will be really accompanied and will be followed by a faster visual recovery and faster, especially symptomatic recovery with less symptoms like pain, light sensitivity, and discomfort. This video is relevant. I think that this technique can be useful for many surgeons performing collagen cross-linking, a very frequently performed procedure because the frequency of keratoconus has been detected to be much higher than expected, and definitely helps the practical surgeon and the patient in order to have a faster visual recovery and a better life in the immediate post-op of collagen cross-linking. I thank you very much for your kind attention.
The journey started when the great Theo Seller invented collagen cross-linking in 1995. We were so impressed that we went to Rome to learn from his lecture in 2005. Then after reviewing the literature, we finally started collagen cross-linking with Dresden protocol. As we observed that riboflavin was spreading in stroma under intact epithelium also, so we started partial epithelium removal method for collagen cross-linking in 2009, which gave equally good results. But what were we worried about? There was patient discomfort, post-operative pain, longer recovery time. There was corneal haze, infective keratitis, corneal ulcer, corneal scar. There was difficulty in pediatric patients. Every accomplishment starts with the decision to try. Time and studies have proved that conventional cross-linking is better than accelerated cross-linking in improvement of corrected distance, visual acuity, Kmax reduction, K-mean reduction or flattening with a deeper demarcation line. Similarly, epi of conventional cross-linking scored better than epi on collagen cross-linking in all aspects. And then there was an issue with post-operative pain, which showed reduction in 5 days with oral painkillers. So, is there a technique which could eliminate all these problems? Yes, it is pupil-sparing partial epithelium removal, collagen cross-linking. We did a retrospective study from January 2012 to January 2018, which included 527 eyes of 331 patients of keratoconus, including 7 eyes of 5 patients of post-LASIK keratoconus. It included eyes with progressive keratoconus of more than 1 diopter over 12 months from age of 8 to 35 years, post-LASIK keratoconus, 25 eyes with thin corneas of 380 to 400 microns which were treated with hypotonic riboflavin drops. Exclusion criteria included coexisting ocular conditions like uveitis, corneal scarring, corneal thickness less than 380 microns, and Kmax more than 70 diopters. After putting anesthetic eye drops, corneal epithelium was mechanically debrided in vertical full thickness strips 1.5 to 2 mm wide with 1 mm distance between them using a blunt hockey stick knife. Parallel rows pattern epithelium debridement with central 2 to 3 mm zone corresponding to the pupillary axis was spared from debridement. Another case shows radial rose pattern epithelium debridement with 2 to 3 mm pupillary zone sparing followed by 0.1% riboflavin drops applied every 5 minutes for 30 minutes. Conventional Dresden protocol with 3 mW per centimeter square of UVA radiation of 370 nanometer for 30 minutes, giving a dose of 5.4 joules per centimeter square at a distance of 5 cm from cornea was followed in all the cases. This is a graphical representation showing both the techniques of pupil-sparing partial epithelium debridement using hockey stick knife. The riboflavin drops spread uniformly into stroma vertically as well as horizontally, suggesting that pupil sparing can be an effective technique for treating ectasia. There is a uniform spread of riboflavin drops in corneal stroma seen on slit lamp right after the surgery. Patients were followed up at day 1 and 2, then month 1, 3, 6, 12 and 18 months, then every year. Post-operative treatment included no BCL. Eye was patched with antibiotic and lubricant for 24 to 36 hours until the epithelium was healed. Painkillers were given only for 24 hours. Post-operative regime involved antibiotic eye drops for 4 times per day for 1 week, 0.1% of fluorometholone eye drops 4 times per day in tapering dose for 3 weeks, lubricating eye drops for 4 times per day. Visual rehabilitation with glasses or contact lenses was done after 3 to 4 weeks. Post-operative day 1 showed comparative clear central area in cornea on slit lamp. Post-operatively, the Wong Baker Pain scale in our cohort was 2.8, which reduced over next 48 hours with only one oral painkiller on the day of surgery. Patients were happier with pupil-sparing partial epithelium debridement post-operatively. Post-C3R outcome were analyzed based on demarcation line on OCT, corneal densitometry and topography using pentacam, and corrected distance visual acuity using Snellen chart on all follow-ups. Mean depth of demarcation line in center of cornea was 288 microns on OCT. It was observed between 4 to 6 weeks post-operatively. This is a case example of keratoconic patient which shows regularization and flattening with significant reduction in keratometry and improvement in the visual acuity. This patient had a good contact lens tolerance. Significant or good flattening and regularization of the cornea was observed in all patients undergoing this procedure, and it was maintained over follow-up of more than 18 months, suggesting that this procedure has good efficacy. 7 eyes of 5 patients of post-LASIK ectasia were treated. This is one of the case example of a post-LASIK patient which shows similar outcomes as that of our keratoconus patients in terms of flattening and the visual acuity. There was a statistically significant difference between preoperative and postoperative flat K and steep K values at 3, 6, 12, 18 months. There was not much change noted between pre-op and post-op thinnest corneal thickness. The advantage of our technique over conventional one was that none of the patients developed haze clinically, which was confirmed on densitometry findings on pentacam over 1, 3 and 6 months. This technique offers less postoperative pain and for less duration. It has minimal chances of infection because of no use of BCL and early healing of corneal epithelium. There is less central corneal haze as subepithelial haze in pupillary area was avoided due to pupil-sparing epithelium debridement. It is well tolerated in pediatric patients. There is early visual rehabilitation with contact lens or glasses in 3 to 4 weeks with faster getting back to original lifestyle, and it is cost effective. The mean K max flattening was 0.81 diopters at 1 year. The mean corrected distance visual acuity improvement was 1 line in Snellen chart at 1 year. The mean depth of demarcation line in center of cornea was 288 microns. There was no central corneal opacity or scarring. It was equally effective in thin corneas and post-LASIK keratoconus. By using our technique, we can avoid many possible complications of collagen cross-linking without compromising its effectivity.